Hi everyone, thank you for joining us. Tonight we have a special guest, Abigail Gowland, is going to give us a teaching on post-MI complications and echocardiology for that. So Abby's got quite a unique role. She's a critical care cardiac physiologist and is the lead cardiac physiologist for critical care at Guy's and St Thomas' Hospital. So she runs or runs the teaching for a critical care accreditation program for fellows, and is a really great person to learn off, both for echo in general and for if you're wanting to accredit an echo yourself. I will hand over to you, Abby, to introduce yourself any more if you'd like to, and please everyone keep your microphones off, and I will share a feedback form at the end for everybody to fill out. Thank you.
Thank you for the introduction. I don't really have much more to add, but yes, I'm Abby. Thanks for joining this evening. It's hard in the evening to motivate to come out and listen to a presentation, but thank you for inviting me to speak. So yes, I've been asked to talk about echo in post myocardial infarction complications. So yeah, I'm just going to work through a few things, and I hope you find it helpful. So as you know, echo is a standard tool in the management of patients presenting with an acute myocardial infarction. So these events cause permanent damage to the heart muscle due to inadequate oxygen supply, and this impairs both diastolic and systolic function. Additionally, an event like this can lead to serious complications, and those patients with large infarcts or those who do not receive timely therapy remain at risk for mechanical complications. So the unstable patients we tend to see on intensive care usually present with cardiogenic shock. 80% of these is LV predominant shock, and 20% is due to RV dysfunction and other mechanical problems, such as LVOT obstruction. It's important to make this diagnosis early because of the mortality rate of these conditions require early intervention, which obviously improves outcomes. The incidence of cardiogenic shock following an acute MI is reported to be about 5% in 15. So as I mentioned, echo can not only detect LV, RV, and LVOT obstruction, but can also detect mechanical complications and pericardial complications. The most common mechanical complications that I'll talk about today includes acute ischemic mitral regurgitation, ventricular septal defects, aneurysms, free will rupture, and each complication is associated with a significant risk of morbidity and mortality. And the care for these patients with mechanical complications is complex and requires an MDT approach, from prompt recognition from the echo and imaging that you've done to diagnosis, to stabilize the patient, and also the selection of therapies or palliation. And as noted on this list, echo is also increasingly used in the ITU for hemodynamic monitoring and also for guiding titration of the therapies for these patients. So I'm going to start with heart failure with reduced EF. So ejection fraction is one of the most important predictors of mortality after having a myocardial infarction. With these acute events, systolic and diastolic dysfunction occurs, and the diastolic dysfunction leads to pulmonary vascular congestion, whereas the systolic dysfunction is principally responsible for depression in the cardiac output. There's a 20 to 30% incidence of heart failure with reduced EF in these patients presenting with an acute MI, and this is obviously associated with a poorer prognosis. The severity of the MR or the location of the infarct and also the patient's pre-existing cardiac health can all influence the likelihood of developing reduced LV function. And heart failure, as you are all aware more than I am, but heart failure after an MI can present with a range of symptoms, including shortness of breath, fatigue, swelling in the legs, irregular heart rate, which often either develops acutely, how we see on ITE, or it can develop gradually. So I'm just going to go through the echo features of heart failure with reduced EF. So areas of ischemia or infarction will demonstrate reduced systolic thickening of the myocardium. So the area of the heart muscle which has reduced function can be described as a regional wall motion abnormality. So regional wall motion abnormalities can precede both ECG changes and symptoms. And the decreased motion is described as either hypokinetic. So if you have a segment of the heart which is hypokinetic, it means that it contracts. There's 30% thickening rather than normal thickening. You can have akinetic function, which is little or no thickening. And then you can have dyskinetic or aneurysmal, which is paradoxical motion in systole. When assessing regional wall motion, it's also really good to assess the myocardium. So thinned and fibrotic wall segments indicate previous ischemic damage, usually an old infarct, while segments which have normal wall thickness but impaired contractility suggest more that the presence of ischemia is more acute than something that had happened before. Also to note, when looking at LV function, when it's severely impaired, the cavity, so the LV cavity doesn't really change in size in systole. It remains a similar size to it does in diastole. So the LV ejection fraction should be quantified visually or by volume method if the images are adequate. And LVOT VTI gives you a measure of overall cardiac function. So just to note, a normal left ventricular outflow tract VTI typically falls between the range of 18 and 22 centimeters, and this represents the distance that the blood travels in one heartbeat. And so this can be used as a measurement for assessing stroke volume, which is really helpful on the ITU. And an LVOT VTI of less than 15 centimeters is associated with poor prognosis. And then also with heart failure, with reduced EF, you get LV dilatation. And this occurs as the heart attempts to compensate for the loss of contractile function by increasing the size of the LV, which then leads to increased wall stress. And this is like a vicious cycle. The increased wall stress also then contributes further to LV dilatation. So we're going to have a quick look at this echo. I don't know if anyone wants to shout out, or I can talk through it. It's up to you. What do they think? Or I can talk through it. So I'll just talk through it. So the top view is an apical four-chamber view. And when assessing LV function, we like to zoom into the view so it fills most of our sector width. And so you can see just initially the cavity of the LV remains very similar throughout the cardiac cycle. And then you can also see that there's areas of the heart which are functioning a little bit better and a little bit worse. So if we start with the septum, so this is your inferior septum. You can see in systole, it moves away from the cavity. So it would be described as dyskinetic. So it's moving away in systole, it's not contracting and coming in how you would expect. The apex actually has quite preserved function there, which is good. But again, just a note here, in the four-chamber view, it's very easy to foreshorten your images. So always make sure you've got well-aligned images, because otherwise the apex can always look like it's got good function. But I think these images are nicely aligned and the apex has got preserved function. And then that's your anterolateral wall. It's not quite akinetic, but it is very hypokinetic. And then moving on to the two-chamber view, which is your second image from the bottom. You've got your inferior wall on the left and your anterior wall on the right. So your inferior wall is very bright and also akinetic. It's not moving at all. And your anterior wall has better function, although it's probably still hypokinetic. And then the bottom left image is a nice three-chamber view, demonstrating that the infralateral wall is akinetic. That's the wall on the left. The apex, again, has preserved function. And again, the septum is actually bowing away from the cavity in systole, so it's dyskinetic. So overall, we'd describe this function as severely impaired LV systolic function with regional wall motion abnormalities. We would then describe each regional wall motion abnormality, and then we would estimate an ejection fraction. So say estimated EF, it's definitely under 35. That's the severe range. We'd probably say it's about 20 to 25. And then we would quote our LVOT VTI, which is in the bottom right there, which is just 8. So our forward flow, our stroke volume is also really low. So this patient isn't compensating that well with this severe LV dysfunction. So the management for this patient would be to obviously address the underlying ischemia, offload them with diuresis. If the patient is hemodynamically unstable, perhaps initiate inotropes to increase the contractility of the myocardium and therefore in turn increase the stroke volume, and appropriate vasopressors to ensure organ perfusion. But also being mindful, if you're increasing vasopressors, that your afterload will increase to the LV, and this may not help the function of the left ventricle. Then also in these patients requiring more support, perhaps mechanical circulatory support may be considered. And then moving on to just regional walls, just touching a bit more onto this really. So like I said, our echo needs to describe the overall function. Either it's globally impaired or regional. We're going to focus on regional because we're talking about myocardial infarctions. And echo is really good to be able to predict which vessel or which coronary artery is causing the ischemia by which segment has reduced function. So just having a quick look at this diagram here. Each part of the heart is perfused by a different coronary artery. And if we just remember back to the echo that we've just seen, so we had akinetic function of the inferior wall and the infralateral. So that would be the vessels perfusing that would be the left circ and the RCA. And then we had hypokinesia of the anterolateral wall, and that would be the LAD or circ. So from the echo, we can predict which coronary artery is the culprit, which I think is helpful. And then again, so obviously you describe the regions affected, and then if you have compensatory hyperkinesia, that's a really good sign. So often you have dysfunction of certain areas, and then the other walls are working really well because it's trying to compensate, and that's a good sign. If other walls are hypokinetic, that could suggest multivessel disease and is a poor prognostic sign. And again, if you can't see all the wall segments and it's going to change the management of the patient, you may also consider contrast echo, which would make your images more clear and easier to evaluate function and regional walls. So this is another echo. Again, if anyone wants to have a go, they're welcome to talk through it. So yeah, I think to talk about the overall function again, we would say it looks severely impaired. It's definitely less than 35%, which is our cutoff for severe. It definitely looks regional. So if we look in the parasternal long axis view, the infralateral wall is contracting reasonably well. It's sort of preserved, but this apex anterior septum is completely akinetic. But the thing to note here is that the wall thickness is normal. Well, it's increased actually. Looks like he's probably hypertensive. So it's not thin and akinetic. So this suggests that there's some sort of an acute ischemia happening. And then in the short axis view, this really nicely represents the regionality of this. So the inferior and infralateral wall are contracting reasonably well at this mid-level, but the septum and the anterior wall look quite akinetic. And again, in the four-chamber view, the anterolateral wall has preserved function, but the remaining segments are akinetic. And then in the two-chamber view, this is the inferior wall and the anterior wall, which we can't see very well. But there's preserved function from the basal to the mid. And then there's akinesia of the apical segments and apex, and it's difficult to see the anterior wall. If you can't see something, it's always better to say you can't see it than to pretend you know what you're seeing. And then the three-chamber view shows you what the parasternal long shows you, that the infralateral is contracting reasonably, but the apex and anterior septum is akinetic. So yes, in your echo report, you say severely impaired function with regional wall motion abnormalities. You'd quote your EF, and then you would also quote your LVOT, VTI, and stroke volume to help manage the patient. So this patient actually had critical stenosis of the proximal mid-LAD with severe stenosis of proximal RCA, and he had revascularization, and he was put on a balloon pump because he was in cardiogenic shock. So now just moving on to right ventricular infarction. So this is typically seen in 30% of cases who have an MI where there is an inferior wall myocardial infarction, and in 10% it causes hemodynamic compromise. Symptoms may include peripheral edema, especially distension of the JVP, hypoxemia, and hypotension. Interestingly, in right ventricular infarction, you'll get clear lung fields because the impaired RV function leads to a reduced preload to the LV, which means less blood is being pumped to the lungs. Early recognition is crucial because the RV is preload dependent, and its dysfunction can lead to reduced LV preload, therefore decreased cardiac output and systemic hypotension. So from the echo, you'll see, you can see in the top left-hand image, we can see that the RV, we're focused on the RV, so this is a nice RV focus. Sorry about the clip, it's sort of jumping. But you can see there's a prominent moderator band, which often means that the RV is dilated. And just looking at it visually, the function is severely impaired. It looks akinetic, actually, the free wall. So there's no longitudinal function. So the tricuspid annulus isn't moving at all up and down. And then there's no radial function either. So just visually, this is severely impaired. Obviously, with the RV, it can also be regional, so it's good to note that if you see that. And it's always often associated with an inferior MI. So with the LV, often you can see the two-chamber here. We can also see it is with an inferior MI, so you can see the inferior wall is down, but the anterior wall is preserved. And again, in the four-chamber, it's good to have a look to see what the septum's doing. And you can see that because of the RV dysfunction, it would be having RV volume overload. It's causing the abnormal septal motion of the LV, which will also affect filling of the LV. And obviously, if this is associated with simultaneous LV ischemia, the symptoms of hypotension and cardiac failure may be really pronounced. So the primary treatment for RV failure is early revascularization through coronary intervention, aiming to restore the blood flow to the affected areas of the heart, and also to carefully optimize fluid status, as patients may require fluid resuscitation in acute RV failure, but can really easily become overloaded, so you have to be really careful. Inotropes such as milrinone can improve myocardial contractility and cardiac output when necessary, but again, should be used with caution. And vasodilators may also be beneficial to decrease the pulmonary vascular resistance. And as you can see from the echo, because of the RV dilatation and impairment, you can see the coaptation of the tricuspid leaflets is impaired. You see this tenting in systole. So this will usually come with concomitant tricuspid regurgitation, which just adds to the increased RV pressure and overload. And an uncommon but very important consideration is the patient who is being treated with inotropes for severe LV failure post-acute MI, but also has this underlying LVOT obstruction, for which inotropes and usual treatment for LV failure, that treatment's contraindicated in these patients. So the clinical findings would be hypotension, and also clinically, they would deteriorate as it would be exacerbated by inotropes and vasodilators. And on the art line, you might see a swing, and you may hear a systolic murmur. So dynamic, I'm just going to get my echo images to play. So dynamic LVOT obstruction is due to the combination of a high flow in a narrow LVOT. So this is your LVOT here, your left ventricular outflow tract. And this generates a Venturi effect in the LVOT. And as a result of this Venturi effect, what it does, it pulls the mitral valve into the LVOT during systole. And that this partially obstructs the LVOT and results in a marked decrease in stroke volume. So these images show a patient who's had a massive, large LAD infarct, and you would describe this as sort of apical ballooning, sort of akinetic aneurysmal, ballooning. And you can see the bottom here, the basal segments are quite hyperdynamic. And again, you can see this patient actually has a quite significant basal septal bulge, which predisposes the patient to having an outflow tract obstruction. This similar pattern is similar to what you would find with Takotsubo, but obviously this patient did have coronary artery disease, so it was that rather than Takotsubo. So because of this hyperdynamic function of the basal segments, this Venturi effect is more pronounced. And so what happens when the mitral valve is pulled and tethered towards the LVOT, it causes malcoaptation of the leaflets, and you get usually a significant posteriorly directed jet of regurgitation. And the obstruction you can interrogate using continuous wave Doppler, and this patient had a gradient across this of 50 millimeters of mercury, which is significant. And so for these patients, things need to be changed. So if they hadn't have done an echo on this patient, they may, because of the clinical scenario, they might want to increase vasopressors and inotropic support. But actually for this patient, it would cause the patient to deteriorate. So for these patients, the best thing is to carefully increase preload, gently increase the afterload, avoid inotropes, because this would make these segments function even better, and also to try and rate control these patients if possible. Now, just to move on to mechanical complications of an MI, which includes papillary muscle rupture, ischemic secondary mitral regurgitation, ventricular free wall rupture, and ventricular septal rupture. All of these have a bimodal peak, so very high risk to happen within the first 24 hours. Then the risk peaks again about 3 to 5 days. So good clinical skills at the bedside, raising the clinical suspicion with a bedside echo is really important for making early diagnoses for these complications, and it means the patient will be more likely to survive. These conditions are a surgical emergency and will require early referral to specialist surgical centres. It requires an NDT approach, discussion about treatment options, including palliative care, especially in the era with mechanical circulatory support such as ECMO, which can allow a bridge to therapy to surgery and can improve the surgical mortality rates. And also ECMO and things like that allows for reperfusion and better tissue healing. So first I'm going to talk about acute mitral regurgitation. So the causes of MR after an acute MI include ischemic papillary muscle displacement. So because of the LV remodeling and dilatation, it causes tethering and movement of the papillary muscle, which distorts the mitral valve function. But the mitral valve is normal in these patients. And then another reason for acute mitral regurgitation would be papillary muscle partial or complete rupture. And it is quite a high percentage, between 17 and 40% of patients who've suffered an acute MI show early clinical or echo findings of MR. So first I'm going to talk about ischemic MR. So the ventricular remodeling, as I mentioned, is the main causal factor of this. And the papillary muscle displacement that creates, let me actually go back quickly. Where is it? No, it's not there. No, don't worry. That's what I thought I'd missed something. So yeah, ischemic MR is MR which is induced because the LV, after an acute MI, because of the regional wall motion abnormalities, it causes displacement of the papillary muscles. And as you can see from this diagram, this is a normal one. So this is a normal sized LV, and the papillary muscle is here, and it causes, it has normal tension on these cords. And when the valve closes, it has a nice coaptation zone. Whereas you can see here, this patient's obviously had a posterior infarct, which causes dilatation, which causes the pap muscle to withdraw and cause tethering on the leaflets. So as you can see in systole, there's not good closure, there's not a good coaptation zone, and we have this coaptation gap. And how the leaflets look here, we call this tenting. And this then comes with a usually central jet of regurgitation. And the clinical presentation for these patients would be systolic murmur, pulmonary congestion, and or cardiogenic shock. So the echo features of this is obviously our patient would have abnormal LV function, and as you can see here, this patient has got impaired LV, which is regional. You can see this basal portion here looks preserved, but can you see the mid to apical segments are impaired, which is causing the papillary muscle to be causing tethering of the cord, and therefore the leaflets aren't closing properly. And you can see the leaflets don't have a good coaptation zone, and there's a gap in systole causing this moderate regurgitation. And this is also demonstrated by this continuous wave Doppler. The more blood flow that comes back, the more dense your continuous wave Doppler will be. So for these patients, again, address the underlying ischemia, reduce the preload, so diurese them. You might want to increase contractility if needed, but this can sometimes make the MR worse. Reduce the afterload using perhaps an intra-aortic balloon pump. And these patients usually don't require sort of surgical intervention. It's normally medical therapy. Because after surgery, the correction of the MR will mean that this already failing LV will have an increased afterload and may deteriorate the LV function even more. So now I'm going to describe or talk about the PAP muscle rupture. So the incidence of acute severe MR from a PAP muscle rupture, like other mechanical complications, has declined in the reperfusion era, but the reported hospital mortality rate remains quite high, between 10 to 40%. As you can see from this diagram, the mitral valve is supported by two papillary muscles, your anterolateral papillary muscle and your posterior medial. The anterolateral PAP muscle has a dual artery blood supply from the LAD and the diagonal, and the posterior medial PAP muscle only has one single blood supply from the circumflex. Therefore, this PAP muscle is the one which is most likely to rupture. And in this nice short axis view, this is your posterior medial PAP muscle, and this is your anterolateral PAP muscle. So PAP muscle rupture commonly occurs within days of an acute MI, and roughly half of the patients present with pulmonary edema that may quickly progress to cardiogenic shock. A murmur may be absent because of the rapid equalization of LA and LV pressures, but echo can be helpful in establishing the diagnosis of acute MR secondary to this condition. Although it may be recognized that from transthoracic echo, it can be non-diagnostic. So a transesophageal echo has a much higher sensitivity. So your threshold, if you're worried about PAP muscle rupture, your threshold for TOE should be very low. And here's some echo findings. Here we go. So as you can see, the top view is a parasternal long axis view zoomed into the mitral valve. And we can see this abnormal mobile mass attached to the cords. So this isn't a complete rupture, but this is a partial rupture. So part of the papillary muscle head has come away, and you can see it's very mobile. And what it's doing, it's causing the anterior leaflet to not coapt well with the posterior leaflet. It's bowing and prolapsing behind the posterior leaflet in systole, because of the tension of the cords are no longer there because of the rupture. And in the short axis view, you can see this very mobile structure here, which is not a normal appearance of a papillary muscle. It should have an attachment here, so you can see something has ruptured here. And then again, in the four-chamber view, we can see this very eccentric mitral regurgitation, which is posteriorly directed because of the anterior prolapse. And it's very eccentric and coandering around the left atrium. It's sometimes difficult to see where the mitral regurgitation is on these eccentric jets, but what we can see is this huge proximal flow acceleration, which suggests that this mitral regurgitation is very significant. And again, the other thing to note is the left atrium actually looks quite normal size. So this isn't a chronic MR, but something acute that's happened. So acute papillary muscle rupture is a surgical emergency requiring immediate evaluation by the surgical team. But the emergency use of temporary mechanical circulatory support may be used as a bridge to theatre. And also, we've had some patients who are too high risk for surgery, and so we have done some percutaneous mitral valve edge-to-edge repair, which can help not eliminate, but reduce the amount of regurgitation and help the patients to get better. So I'm just going to show you an example here. So this is a TOE, a transesophageal echo. So I'm going to show you the pre-TOEs here. So I don't know if you're familiar with TOE, but this is the left atrium, this is the mitral valve, and this is the left ventricle. And so really nicely, this is actually the same patient as the one I showed you before, but really nicely you can see that the anterior leaflet is flail, it's prolapsing behind the posterior leaflet in systole. And just visually, you can see a massive coaptation gap, which would make you think, even without colour, that there's going to be significant regurgitation. We can also see sort of something slightly mobile flicking in and out, which is the partial pap muscle rupture. And then with colour Doppler, you can see this very high turbulent, eccentric, posteriorly directed regurgitation going back into the left atrium with a really big flow acceleration, so a really big Pisa. And again, this is like your bicommissural view. You can see this abnormal pap muscle here and the prolapse of the anterior leaflet with a coaptation gap. So this patient, they then put a clip in, a mitral clip, and you can see even just visually, you can see that the leaflets are coapting better. There's no longer this massive gap between the leaflets in systole. And again, the mitral regurgitation has lessened, although it's still there, it's lessened. And this patient particularly was on lots of support going in, and after the mitral regurgitation had lessened, his support decreased significantly. So it really helped the patient, even though he wasn't a surgical candidate. And again, this is just another one. So this patient had a STEMI in his local hospital. He had 4 stents inserted and he was doing fine, but then suddenly he deteriorated on the CCU at his local hospital and had significant pulmonary edema. And so they did a transthoracic bedside echo, which showed a new severe mitral regurgitation, and they weren't sure whether there was a pap muscle rupture. So the patient got transferred to St Thomas's to be admitted to the ITU and worked up for surgery and the potential candidate for ECMO. And obviously, it's really important to know whether it's a pap muscle rupture or versus just ischemic functional MR, because it really changes the management of the patient. So the patient came across and his TTE images weren't great, but we could see this very eccentric regurgitation. So we went on and did a transesophageal echo. And as you can see, this is a nice 3-chamber view. This is the left atrium, the left ventricle, and the left ventricular outflow tract. In systole, we can see this abnormal motion of the posterior leaflet, a flail leaflet, which is coming behind the anterior leaflet in systole, and this abnormal motion of the papillary muscle. So this was a complete rupture of the pap muscle. And again, this is concomitant mitral regurgitation. This is the other way. This is anteriorly directed now. Again, we don't see much of the regurgitation in the left atrium, but we see this huge flow acceleration, which means it's severe mitral regurgitation. And just to note as well, we've got a very hyperdynamic LV, which comes with severe MR because of the overload. And this is just a nice 3D view of the mitral valve. This is the anterior leaflet at the top and the posterior leaflet. And in systole, we can see the the posterior leaflet is prolapsing just here in systole. So this patient was well enough to go for surgery. So he went on to have his mitral valve surgery and is doing really well. And this is his post-op TOE, which shows a really good functioning normal tissue mitral valve, leaflets opening well, good coaptation, and no longer any mitral regurgitation, just normal laminar flow through the valve and no MR. And he was discharged and is doing well. So ventricular septal rupture occurs in the zone of necrotic myocardial tissue, and this normally happens within the first 10 days of an acute event. The incidence of this has decreased and is around 0.3%. And the risk factors include older age, being female, and delayed reperfusion. The presentations range from an incidental murmur to cardiogenic shock. And the symptoms may include dyspnea, orthopnea, and clinical examination often reveals hypotension and all different things attributing to low cardiac output with a new murmur. Ventricular septal rupture occurs in approximately 3 to 5% of myocardial infarctions. Anterior and apical ischemic ventricular septal ruptures are caused by infarcts by the LAD territory, but posterior ruptures are caused by the inferior infarcts. And you can get right ventricular infarction or ischemia, and this is an important feature of ventricular septal defects because it can cause the low output. And often posterior VSRs are often accompanied by mitral regurgitation, commonly because the tethering of the mitral valve. I'm just going to show you an example here. So on the echo, you can see, just visually, you can see that there's a gap in the septum. So there is a hole in the ventricular septum. You can also see that the inferior septum is akinetic, it's not moving. So that is obviously the part of the heart which is infarcted, and it's caused this hole. So it's really important to interrogate the septum really well in lots of different views and alternative views to check that there's no septal rupture. And this is demonstrated really nicely from color flow Doppler. So you can see that there's a systolic left to right shunt into the right ventricle. And again, in the short axis view, this is a slight alternative view. I'm sort of between the mitral and the pap muscle view. We can see this quite large rupture of the myocardium with this left to right turbulent high velocity shunt. And this can also be demonstrated with a continuous wave Doppler. And it's quite nice to get really good alignment and to see what your maximal shunt across this rupture is. Given the high mortality rate associated with uncorrected defects, conservative medical therapy alone is limited to patients with who are hemodynamically, is limited to those defects which aren't significant. And we would try and do effective afterload reduction to decrease the left to right shunt. So intra-aortic balloon pumps are used for these patients. And obviously surgical management is the ideal for these patients, or percutaneous repair, depending on how fit the patients are for surgery. The timing depends on shock and also end organ function. And then I'm just going to talk about aneurysms and pseudoaneurysms. We're nearly done. I think I've only got a couple more slides. So a true aneurysm complicates about 5% of all anterior infarcts and is a sign of poor prognosis. But a true aneurysm needs to be distinguished from a pseudoaneurysm. So a true aneurysm is more commonly seen in the apex, and it has a wide neck. And the lining of the aneurysm is the myocardium. So the border zone, you often see gradual thinning into this akinetic and aneurysmal section of the LV. And the flow within it, when you interrogate by colour, it's normally very slow and sluggish, and sometimes you see spontaneous contrast within the aneurysmal section. But versus a pseudoaneurysm, which is more commonly seen inferior laterally, and the neck is normally much more narrow than a true aneurysm. And the big difference is that the lining of the aneurysm is pericardium. So there's a rupture through the myocardium, and the lining is pericardium. And you see flow go in systole and out in diastole. So this is echo findings of a true aneurysm. So as you can see, the top view is apical four-chamber view. And you can see that the basal to mid segments look normal wall thickness, and the apical lateral wall has normal wall thickness here. And then gradually you see thinning of the myocardium going into this aneurysm. And again, in the two-chamber view, you can see the apical segments are aneurysmal and akinetic. And if I was to put color Doppler on here, it would be very low flow, low velocity. And it's really important with these patients to zoom into the apex, because obviously this stasis of blood flow can really predispose these patients to clot and thrombus. So the management of these patients depends on the severity, but normally it's medical management. And perhaps CRT devices and things, because they get arrhythmias as well. Whereas a pseudoaneurysm is like I was mentioning, it's like a sac-like outpouching with a narrow neck. And you can see that this mobile thing here is actually the myocardium with a rupture going through it. And so the thing which is containing the aneurysm is the pericardium. So you can see that this patient's obviously had an apical infarct, and this is just zooming into it more closely. This is the pseudoaneurysm, and this is the rupture of the myocardium. You can see blood going in and out. And obviously these patients, this is an emergency. These are highly likely to rupture, and so they would need urgent surgical or percutaneous repair, also depending on symptoms. And then we can get a free wall rupture. So a free wall rupture is a devastating yet relatively rare complication following an acute MI, and it occurs in less than 1% of cases, but is really associated with high mortality rates. And this condition involves the tearing of the LV wall, leading to catastrophic bleeding, cardiogenic shock, and often death if it's not promptly treated. Symptoms can include severe chest pain, hypotension, and signs of cardiac tamponade. But the overall incidence of this has got better since better reperfusion therapy. So unfortunately, I actually don't have a case for this, so I had to sort of steal these pictures. So they're not moving images, but it shows you, it demonstrates what we're talking about. So a free wall rupture should be suspected in any patient with hemodynamic instability or collapse after an acute event, especially in the setting of a delayed or ineffective reperfusion therapy. And so it's fatal, but occasionally a prompt bedside echo confirms the diagnosis, and then they could go for emergency surgical correction. So the echo demonstrates a gap again in the myocardium and also a pericardial effusion. And if you're lucky, you can put color Doppler over here, and you can see the flow going into the pericardial space. The pericardial space can sometimes, although it's a pericardial effusion, it can be echo dense as well, with clot and blood in. And it's normally the free wall rupture is normally associated with the regional wall motion. Contrast may be helpful for patients if you can't, if your suspicion is high and you have a pericardial effusion, it would be useful to use contrast. And what you'd do, you'd opacify the left ventricle, and you'd see contrast filling the pericardial effusion. And again, this is a right-sided free wall rupture, and you can see color Doppler coming out of the RV into the pericardial space. And you can use agitated saline for right heart free wall ruptures. So the management for these patients, obviously immediate surgical repair unless too high risk, and immediate placement on ECMO may provide an opportunity for stabilization. So echo can also pick up pericardial complications. So the incidence of pericarditis following an MI is currently considered to be around 5%, with the majority of cases occurring as early pericarditis. So that would be within the first few days. But this rate has significantly decreased due to improved reperfusion therapies, making the late onset of Dressler's syndrome very rare. So after an MI, a pericardial effusion can happen because of an inflammatory response of the because of the myocardial damage, or it can happen because of actually the procedures that you're doing. So it can be caused by the intervention. So it's really important to, if you have a high clinical suspicion of a pericardial effusion, to do an emergency echo. So with a pericarditis without an effusion, here you can see you see a thickened and bright pericardium. With these patients, it's more like a constrictive pericarditis. You would also have a septal bounce, and your IVC will be dilated and not reactive. With pericarditis with an effusion, like down here, you'll see this echo-free space around the heart, and it can sometimes have echo-dense material, as I mentioned before, clot or even fibrin strands. And so our job from the echo point of view is to assess the size of the effusion and also to assess how significant the effusion is by echo. So obviously echo findings for hemodynamic compromise include to see whether there is RV diastolic collapse, and also a dilated and unreactive IVC, and to look at your mitral and tricuspid inflow variations. So all of this just adds to your clinical opinion about the patient. So obviously from echo, we can't diagnose tamponade, but it can help, but tamponade remains a clinical diagnosis. And depending on the cause and the symptoms of the patient, they may put a drain in, antibiotics. It depends on the reason for the pericardial effusion. And lastly, an LV thrombus can happen after an anterior wall MI. So a reduced LV function is a significant risk factor for thrombus formation. And most thrombi occur in the area of the apical wall motion abnormality. So as you can see from these pictures, to be honest, it looks quite globally impaired, the top one. But the apex is definitely akinetic. And what you can see echo-dense material within the apex, which is highly suspicious of a clot. And actually this one at the top shows a fresh, newly forming thrombus, because you can see well-defined edges, but the middle is still blood. So usually clots are higher density, as you can see here, than the myocardium. And it's always good to make sure you can see them in multiple views, because sometimes we do see artifact that we can think is clot, but make sure we can see it in multiple views. If you put colour over these clots, you would obviously not opacify the apex. There would be sort of a colour void where the clot is. And if your clinical suspicion is high and you can't see the apex very well, and it's going to change the management for the patient, contrast enhanced agents would be advisable. And again, just lastly, clots can be mobile or mural. So mobile are more likely to embolize. That's where they're sort of protruding into the left ventricle. A mural, sort of laminated thrombus, is more compacted to the myocardium and often more tricky to see. These are both mobile clots. And you can also see, actually, he's also got one in his right ventricle there as well. So the management for this patient would include anticoagulation. Just to note as well, a transesophageal echo won't improve your visualization of the LV apex. So if you're querying LV clot, a contrast echo is much better than requesting a transesophageal echo. So just conclusion really, echo is a really valuable tool in diagnosing patients having an acute MI, looking at regional wall motion abnormalities. And also after the acute MI, it provides substantial information regarding the risk stratification and the hemodynamic assessments. And like I've shown, it can detect mechanical complications, and it helps to guide and monitor therapies in patients after an acute event. But that said, it is limited by image quality. So if you're struggling to get good views, always call for help, or perhaps they need other forms of imaging. So yeah, that's it. I hope that was helpful.